So this is about principles of laparoscopic surgery and overview. So I think already you are seeing the topic, principles of laparoscopic surgery and overview. See, I will be discussing about various principles which govern today's laparoscopic procedures. Like you know, a surgeon nowadays without laparoscopy, he is considered handicapped. Gone are those days where if surgeon wants to do only open procedures, so he will be left out by a majority of patients, because nowadays not only the basic procedures, not only lap appendix, even the advanced procedures like lap cholecystectomy, laparoscopic hernia, splenectomy. The other day, Saturday, we were doing lap hydrated cyst. So we finished the entire procedure in laparoscopy. So all major procedures, not even malignancies. Now, like 5 years back, it was considered the colectomies or APR, abdominoperineal resection, and other procedures for malignancies. Laparoscopy was a relative contraindication. See, because what they thought, when you handle a malignancy through laparoscopy, the ports, because you will be putting the instruments into the abdomen, you will be bringing them back. So the tumor cells will soil these ports, and naturally they will open a fresh passage for malignancy to spread. See, for example, a colonic malignancy is there. It will spread to the mesentery, whether it is the inferior mesenteric artery or superior mesenteric artery based on its location. But now, once you handle this tumor, you are seedling the ports with tumor cells. So naturally, a fresh lymphatic passage. Suppose there is an umbilical port. Tumor cells have accidentally been deposited in the umbilical port. So tumor will pass through the surface lymph nodes. Another passage you are opening. So these were some contraindications, but majority of the studies have shown that there is nothing like tumor seedling unless you adopt some clean practices like putting a specimen in a bag. So you have seen after cholecystectomy, we put the gallbladder in a bag. Similarly, any malignancy, so put the specimen in a endoscopic retrieval bag, and if you remove that one, tumor seedling is not at all a problem. So that is why now even laparoscopy has become the route of choice for doing radical hemicolectomies, abdominoperineal resection, or for handling all malignancies. So now all abdominal procedures which were being done in open surgery, every surgery is being done through laparoscopy. So a surgeon to stay competent or to stand among his peers, he should learn laparoscopy, not only basic procedures, he should be able to do advanced procedures. So I will be discussing the basic principles which govern this laparoscopy irrespective of the procedures. So this is the laparoscopy suit you have seen. Surgeon nicely performing the procedure with assistant retracting and one holding the camera, and this is the monitor. Surgeon looking at the monitor and he is doing the procedure. This is the traditional laparoscopic suit. Now, even laparoscopic suits are there in tier 3 towns also. Like for example, you take Nellore. Nellore is tier 2. If you go to tier 3 like Atmakur, Gudur, Kavali, there also surgeons are doing laparoscopy. In fact, a wonderful laparoscopic suits are there. Now, everywhere laparoscopy is available. If you see briefly into the history of laparoscopy, actually, 1 century has passed. In 1901, there is a clinician by name Von Oort. He has tried to do first laparoscopy by putting a scope into the abdomen through that speculum, and in a candle light, he tried to see what is happening inside the abdomen. So that started laparoscopy, but it was dormant for some 60 to 70 years. With good light source and other things, the first lap appendicectomy was done in 1983 by SEM, SEMM. And the first lap cholecystectomy was immediately done after 2 years, 1985, by Eric Muhe. So nowadays, laparoscopic cholecystectomy is the golden choice procedure for to do a cholecystectomy. So prior to laparoscopy, you need to give a Cocker's incision, right subcostal incision, and some 12 to 14 sutures you need to put, a big wound. Whenever patient takes deep inspiration, there will be a catch because of this movement of the wound. So severe pain will be there, and restriction of movements, basal lung atelectasis, respiratory failure. These are the things used to happen. But with laparoscopic cholecystectomy, free movements are there, and it has become as the golden choice procedure. And it was very soon followed by laparoscopic hysterectomy, hernia surgeries. From there was no looking back. In 1 decade, see, the first appendicectomy was done in 1983 and cholecystectomy 85. In 1 decade, by 1995, almost all procedures what you are doing now through laparoscopy, they have started doing. So it evolved at an exponential pace. Now what is happening in laparoscopy is only the instrumentation is changing, but from 1985 to 1995, all procedures what you are doing, they were done and they evolved by means of laparoscopy. Now what is this basically laparoscopic surgery or minimally invasive surgery? As you can see in this representation, instead of opening the abdomen, see abdomen is a closed cavity, instead of opening the abdomen, we put small holes in the abdomen, what we call it as ports. We put ports in the abdomen, and through the ports long instruments are introduced, and through one port a camera is introduced. The image is taken onto a monitor. Looking at the monitor, you will be doing the procedure. The basic difference is, instead of opening the abdominal cavity, you are putting holes in the abdominal cavity and doing the procedure. So that is laparoscopy. Now instead of a traditional big incision, small incisions, that's why it's called as a minimal invasive surgery. Not only abdominal cavity, you have VATS, video assisted thoracoscopic surgery. Thoracoscopy very much similar to laparoscopy, only difference is in VATS you don't need any gas to insufflate, because already rib cage is a rigid one, it's already an expanded one. Abdomen is a collapsed one, you need gas to insufflate abdomen. Except that everything is same like laparoscopy, the thoracoscopy. You have mediastinoscopy, new planes are being developed now. Abdomen is already a cavity, thorax is already a cavity. Now surgeons are exploring newer planes where there was no cavity prior to that one. See, for example, we are doing TEP, totally extraperitoneal repair for hernia. The extraperitoneal space, it's not a cavity, but surgeon is insufflating gas into that one and doing the procedure. Similarly, you have mediastinoscopy, or what is the procedure for varicose veins, where you do SEPS, subfacial endoscopic perforator surgery, where you that subfacial space you insufflate gas. So not only the existing cavities, newer planes are being developed day by day. So in urology, normally they do retroperitoneoscopy. So during donor resections or pyeloplasty, retroperitoneum also they are insufflating. Not only the existing cavities like abdomen and thorax, which are being done through minimal invasive procedures, newer planes are being developed. That with the advent of laparoscopy. Now, so there are certain principles of laparoscopic surgery. When I will be describing about the principles, we will be discussing about the instruments also in parallel. So there is a mnemonic actually. The mnemonic is I vitros. See, normally I don't prefer mnemonics, but this mnemonic is given in Bailey and Love. The new edition, if you see the new edition, Bailey and Love, 27th edition, there is this mnemonic. So we need to discuss about that one, I vitros, where the first one, I stands for insufflation. So one by one we will be going on. The first one is I stands for insufflation. V means you have the visualization, and I vitros, I means another I, that is stands for identification, T for triangulation, R for retraction, O for operative procedure, and finally S for securing hemostasis. So everything, this I vitros nicely explained in your Bailey and Love, you can check that one. We will start with each one of them. Insufflation, because abdomen is a closed cavity, you need to expand that one. Unless you expand the abdominal cavity by putting a gas, you can't operate inside, because there is no operative space. So if you see a normal abdomen, see this is the posterior wall, this is the viscera, anterior wall will be touching the viscera. So there is no space here to operate. By putting gas here, the abdomen will distend. You get an operative field here, operative space. Into that you can put instruments and you can do procedure. So that you call it as an insufflation. Insufflation is commonly done by carbon dioxide. So insufflation is done mainly to get space for surgery. Why carbon dioxide has to be used, that we will be discussing shortly. And how do you insufflate abdomen? So normally we use two instruments. So commonly we go by means of Hassen's cannula. So that you call it as an open procedure. That means around the umbilicus we give a small incision, 1 centimeter incision, or more than 1 centimeter, because the instrument is 10 mm, you need an incision of 12 to 15 mm. We give a incision around the umbilicus, we separate the tissues, layer by layer we open under vision, we identify rectus sheath, we open the rectus sheath, we identify the peritoneum, we open the peritoneum. So that way under vision you open layer by layer, and finally you put this Hessen's cannula into the abdomen. So this has got, you can see here, a carbon dioxide pipe will be connected here. This is the valve like thing. Once you make it on, the carbon dioxide will go through this cannula and into the abdomen. So this commonly we do by means of Hessen's cannula. This you call it as an open technique. So there is one more technique called as a closed technique. So where this is a Veress needle. So what you do is you just thrust this Veress needle into the abdomen, and again it has got a carbon dioxide pipe can be connected here. This is the valve. You can switch it on and carbon dioxide gas will go into the abdomen. Because Veress needle, you don't incise layer by layer. You blindly enter into that one. So you need a safe place. So that is why we select Palmer's point. So you could have heard about Palmer's point. So normally in the left upper abdomen, so some 3 centimeters, some people call 2 finger breadth, or 3 centimeters beneath the left costal margin. So normally the line is the mid clavicular line. So in the mid clavicular line, you select a point which is 3 centimeters below the left rib cage in the mid clavicular line. So there you give a stab incision onto the skin, and this needle will be directly put into the abdomen. The reason why I select with this Palmer's point, you don't get any viscera here, so that nothing will be injured, except suppose a patient is having a splenomegaly, big spleen is there, you will be entering into the spleen. That is why before putting a Veress needle, confirm whether there is splenomegaly is there or not. You can do by means of ultrasound or just palpate the abdomen. If there is no splenomegaly, directly insert Veress needle, it will go into the abdomen. No major, like you don't have any great vessels there, you don't have any coils of intestine, no viscera will be there. So this is called as a closed technique. Now which one is better? So that depends on how the surgeon is trained. Both are equally good procedures, both have got equally good results. With respect to the visceral injury also, both stand to same. So many studies have confirmed that both the procedures are equally good, provided in which one the surgeon is trained. Because suppose the surgeon is well trained in open Hessen's cannula technique, suddenly he was asked to do a Veress needle, he might injure. But a surgeon who is regularly accustomed to that one, both procedures stand good. So that is how you insufflate the abdomen by means of either Hessen's cannula or a Veress needle. And this is the carbon dioxide insufflator you could have seen during procedures. These readings are very important. Normally we don't pay much attention to this one. Sometimes we will be concentrating on this one. See, this is how much pressure is there in the abdomen. So here it is shown 12 millimeters of mercury. So normally we put pressure from 12 to 15 millimeters of mercury. So if you put more pressure, naturally when a lot of pressure is there in the abdomen, inferior vena cava will be compressed. When inferior vena cava is compressed, venous return to the heart will decrease. So naturally to cope up with that one, there will be tachycardia. Whenever there is tachycardia, heart goes into more workload on the heart. Naturally patients who are already prone for, already have a disturbed heart like congestive heart failure or uncontrolled hypertension, naturally they will go into cardiac failure. So that is why pressure to be maintained 12 to 15 millimeters of mercury. Always try to operate under 12 millimeters of mercury. Suppose your space is not that adequate, you can increase the pressure by discussing with the anesthetist. So normally we check this one. The other two readings, the central one, it denotes how much carbon dioxide is going into the abdomen per minute. So here you can see liters per minute, how much inflow is there per minute. See, why this was added means, see for example, you are doing laparoscopy, you have put a cannula, you have connected a carbon dioxide tubing, and suddenly if you see the inflow is 0. So there is no inflow, or inflow is instead of 1.5, that means here 1.5 liters per minute carbon dioxide is going. Suppose if it is 0, that means no carbon dioxide is going into the abdomen. What does that indicate? Either carbon dioxide, this whatever cylinder is there, that is empty from carbon dioxide. You ask the technician to check, okay, carbon dioxide cylinder is adequate. Then in that case you should think your Hessen's cannula or Veress needle is not into the abdomen. It is somewhere stuck to some muscle or in some extraperitoneal space, it is stuck there. So that's why it is not allowing carbon dioxide to go in. So you need to check this one. Similarly, suppose you have a patient where this pressure, this 12 millimeters of mercury, this goes to 0. Suddenly a patient is there where the pressure will be 0, but inflow is 1.5 or 2 or 1. So what does that indicate? That means there is inflow is there, but pressure is 0. So what does that indicate? Yes, either there could be common thing is leak. Carbon dioxide is going in, it is leaking. So you need to check other ports. Or the other one is your Hessen's cannula or Veress needle is inside the lumen of an intestine. So it has directly gone into the intestine. Whatever carbon dioxide is going, that is filling the bowels. It is not insufflating the abdomen. So that is why both these things you need to check whether they are normal or not. And finally, this last one is how much carbon dioxide has gone throughout the procedure. So now basically now they have started the procedure, so it is 0. Suppose you do procedure for some 1 hour, 2 hour, it will say 80 liters, 90 liters has gone into the abdomen. So that is to know how much hypercarbia this patient will be experiencing. So that is about the carbon dioxide insufflator. And this is the pipe which connects from the cylinder to this carbon dioxide insufflator. So you can see this is the connection here. And of course, you have seen in OT, the carbon dioxide cylinder stand will be there. Now, why carbon dioxide is used for pneumoperitoneum? You have several other gases, like you have nitrous oxide, oxygen, or air. There are several other gases, but why only carbon dioxide we use? So the reason is mainly carbon dioxide, one, it's cheap, it's easily available. These are lesser indications, but more important indications for using carbon dioxide is carbon dioxide will be easily soluble in the blood. So whatever carbon dioxide you are pushing into the abdomen, that is easily soluble in the blood, and through patient expiration that will be brought out into the atmosphere. So the exit route is very much easier. First of all, carbon dioxide easily gets soluble in the blood, and whenever the patient is doing expiration, it can be expelled out through the natural route. That is the reason we prefer carbon dioxide. And the other one is carbon dioxide is non-combustible. Like you could have seen carbon dioxide fire extinguishers. Why they use carbon dioxide means it brings down the flame. That is why because you will be using energy devices, monopolar, bipolar, or energy devices. So carbon dioxide prevents catching of fire. So that is why a main advantage of carbon dioxide. And why don't we use atmospheric air? Because air is freely available. Why can't we use atmospheric air? Atmospheric air. See, because atmospheric air, if you use, more chances of air embolism. Like carbon dioxide, air cannot easily dissolve in the blood. So more chances of air embolism. That is very much important. And there might be chances of combustion in normal air also. Suppose air is a bit humid, discharge of when you are using energy devices, there will be discharge of electricity or flame or heat. So for these reasons, air is not normally used. Even nitrous oxide also, nitrogen, the same reason. They more chances of air embolism. You don't use them. And we don't use pure oxygen. That is understood. Though oxygen, like carbon dioxide, it dissolves in blood and it can be expelled through the natural route, but carbon dioxide catches fire very easily. It is combustible. So that is why we don't use oxygen also. And recently, any good alternative for carbon dioxide? Any good alternative for carbon dioxide? Right. Someone was saying inert gases. Like one gas which is being actively tested is helium. So helium is showing better results than carbon dioxide because the problem of hypercarbia. If you study about the physiological effects of carbon dioxide, so whenever you insufflate more carbon dioxide into the abdomen, prolonged procedure, this carbon dioxide dissolves in the blood. So there will be acidosis because of hypercarbia. And the effect, the physiological effects of hypercarbia, not only acidosis, all acidotic effects. So there will be tachycardia, hyperdynamic circulation, again cardiac failure and hypertension. And it reduces the threshold for arrhythmias. So arrhythmias are also more common with hypercarbia, and acidotic effect. All these acidotic effects of carbon dioxide can be countered when you give an inert gas like helium. So helium, it is non-combustible. Another big advantage of helium when compared to carbon dioxide is it's more transparent than carbon dioxide. So naturally the quality of vision is good. So because of all these reasons, helium is being actively tested as an alternative to carbon dioxide. Helium will not be absorbed by the blood. So because it doesn't go into the blood, no change of acid base, no disturbance of the regular acid base balance in the blood. So because helium will not be absorbed into the blood, you need less amount of helium to do the procedure. For a simple lap appendicectomy, we have shown previously, you need some 1 hour procedure, some 60 to 50 liters of carbon dioxide is used. Whereas helium, you can do the same procedure in 3 to 4 liters. Because it don't go into the blood, if you see that the ports are not leaking, it stays in the abdomen. Several studies are showing helium to be superior to carbon dioxide, but it takes more studies to see that helium replaces actually carbon dioxide in regular practice. So that is about insufflation. So the eye vitreous, the first one, insufflation is done. The second one is vision. So you need to see what is happening inside the abdomen. Unless you see what is happening inside, you can't do the procedure. For that you need a camera. So this you could have seen in the OT trolley. The camera will be there. Various companies, Starge, Stryker, multitude of companies are there. This is the camera. This camera, what you do, you will attach it to a laparoscope. So whatever laparoscope is there, through which that is the optical system, you attach this camera to this laparoscope. Now this camera, whatever is happening inside the abdomen, this camera will shoot that one and it will transmit the image into a monitor. So looking at the monitor, you will be doing the procedure. And cameras, various types of cameras are there, like you could be reading about single chip camera, double chip cameras, triple chip cameras. Our hospital, we have actually got a triple chip camera. The basic difference between a single chip and triple chip, now if whatever the image the camera is capturing from the abdomen, in a single chip camera, there will be a single chip. Whatever light is coming, this entire light will be coded, or it will be stored in the form of pixels on this chip, and it will be transferred into image. Whereas you take triple chip camera, there are 3 chips will be there. Whatever light is captured by the camera, there will be a beam splitter inside. So that splitter will split the light beam into 3 colors, the 3 primary colors, the red, green, blue. So it splits the light into 3 colors. Each color is coded or pixelated onto one chip. And finally the image processor will combine these 3 light sources and give an image. The advantage is you get a high quality image by using a triple chip camera, because light is split and each primary color is coded onto one chip, and finally the image is merged. Instead of all the colors coming onto a chip, it gives a high quality image. So that is a triple chip camera. Our hospital has got a triple chip camera. So it sees what is happening inside the abdomen. And light source, because unless you have a light source, the camera cannot capture image. So when you take a photo, your mobile or whatever is there, you need light. If light is not there, you will be putting artificial light. So similarly here, inside the abdomen is not self-luminous. So you need a light source. The light source, you have another light source, another tubing is there. This tubing will be connected to again this laparoscope, and whatever light is there, this goes into the abdomen. Commonly used light source is the argon light source. So that is yellow in color, argon. So the element which produces the light is argon, that is yellow in color. But the problem with yellow light is, suppose you are doing cholecystectomy, there is accidental bleeding. You are throwing yellow light, blood is red in color. When red and yellow mixes up, you get some different brown or some pink in color. So you don't know whether the leaking one is blood or bile or lymph. You don't know whether it's venous blood or arterial blood. So yellow light, mainly the argon light source, though commonly used in cheap setups, it is very hazardous during procedure. So that is why the best one is the white light source. In our hospital we have a white light source. The argon was previously used, but that is no more used. You have the halogen light source, the white one, white light. So white light, the advantage is whatever color is there, it will preserve that color. So whether it is bile or blood, if you throw white light on that one, it won't change its color. So that is the advantage. We have the halogen white light source is there, that we use in our hospital. The yellow light source is not being used. So this is the laparoscope, and so this is what, here we will connect the light source. Light source will be connected here. So white light will go, it travels all the way through the laparoscope and it falls into the abdomen. Similarly, there will be a camera here, it will capture the image, and this image will be transmitted through into the monitor. So this is the channel for transmission of image. So image capture, light source, both travel through this long laparoscope. Again, the principle here is total internal reflection. When light you want to pass it through a long tubing, the principle is total internal reflection. So light reflects from the surface, again it reflects from the opposite surface. It travels reflecting from either surfaces. It can travel to infinite distance based on what is the concentration you are using. So this is the big laparoscope. Again I repeat, here you attach the light source, from here you capture the image, and finally the image will be taken onto the monitor. You have high definition monitors, you have 3D monitors. What we use is a HD, high definition monitor, and finally you can see a wonderful image. You can nowadays some surgeons use 3D monitors also for depth perception. And this is the trolley. As you can see here, you get the final image, and what are all the things we have seen here. So you have the light source. This is the light source, halogen light source. You have the camera will be attached here, and this is the carbon dioxide insufflator. You can see the carbon dioxide tube will be attached here. Finally the image will be transmitted automatically. So this trolley, the back of this trolley, you have a facility to hold the carbon dioxide cylinder also. So that is about vision. So insufflation we have studied. The vision is mainly by camera, light source, laparoscope and monitor. The third one is identification. So how to identify structures? With the advent of laparoscopy, newer methods of identification have come into vogue, which you need to study for each procedure. See, for example, cholecystectomy. Traditionally in open cholecystectomy, we don't speak about R4U line, we don't speak about Rovius sulcus. But with the advent of laparoscopy, because you are doing a remote surgery, you need additional landmarks to do a safe surgery. So that is why during cholecystectomy, surgeon, once he does a dissection, he will check the Rovius sulcus. He will see whether his dissection is above the line joining from the Rovius sulcus to the fourth segment of the liver, R4U line. If the dissection is being done above that line, he is in a safe procedure. So newer identification marks you need to study for each surgery. Say for example, you are doing laparoscopic hernia, the TEP or TAP. You speak about triangle of doom, you speak about triangle of pain. These terminology you don't normally study in open surgeries. So for during laparoscopy, you are operating remotely and in a magnified one. You need to have newer identification marks which for each surgery you need to study, like the Rovius sulcus, R4U line. Suppose you are doing appendicectomy. So normally regular appendicectomy we identify the cecum and we go there. But when during laparoscopy we normally go to we identify the white line. So there are additional identification marks which you need to study for each procedure. And the other one, the fourth one is T stands for triangulation. So this is very important. To do the procedure in a good ergonomical way, you need this triangulation. That means triangulation means putting the ports. You have a camera port, you have working ports, you have retraction ports. Where you need to put the ports, that is very important. If you put the ports in a haphazard way, doing the procedure is very difficult, because in open surgery you have multiple axes. Suppose I have opened the abdomen, I can introduce my hand in this way, I can angulate my hand, I can move my hand in any direction. But in laparoscopy, once you put a port, your instrument cannot pass beyond that port. So port placement is very important, that you comes under triangulation. The commonly followed method is from the target organ. So assume that you are doing laparoscopic cholecystectomy. Gallbladder is the target organ. Your viewing port or the camera port or Hessen's cannula should be put 10 to 15 centimeters away from that one. So umbilicus normally it will be 10 to 15 centimeters away from the gallbladder. So that is how you select. And once you put the central port, draw an arc. If you draw an arc here, what does it mean? The target organ, if it is 10 to 15 centimeters from the central port, you select any point on this arc, it will be 10 to 15 centimeters away, because this forms the center of the circle. This arc is, in fact, it's a big circle, like it's a big circle. So radius is same anywhere. So the other port should be put on the same arc. This gives you good ergonomics. Surgeon need not struggle. You can do the procedure very comfortably. If ports are placed here haphazardly, you need to bend abnormally. Your hand will be hanging. Your neck will be straightened. All sorts of ergonomical disturbances will happen. So put the other ports on the same arc so that they are equally away from the target organ. And the other ports, you have retracting ports and working ports. Always the dictum is the retracting port should be well away from the camera port. See, this is the retracting port. And the working port should be somewhere between retracting and central port. So this is the general principle. But there are modifications, because you have, suppose you are doing lap appendicectomy, you follow a different method. But general one is this one. From the target organ, the central port is 10 to 15 centimeters. Retracting port should be well away from the central port, and working port should be midway between these two. So this is the normal one what we follow. And for example, you are doing lap appendicectomy, we change the ports. So this is the target organ. Now the operating ports are on the same side, but see that all these things form on an arc. So you draw an arc, everything is on an arc, so that they are equally distant from the target organ. So this, if you follow, you get a good ergonomic result. That means surgeon, without any struggle, without any neck pain, back pain, visual disturbance, without any fatigue or spasm, he can easily do the procedure. And you could have heard about the baseball diamond concept, normally by putting ports. So this, the word commonly used, baseball diamond concept. This is nothing but what we have discussed just now. So the target organ is where the baseball, the person who is doing the batting person will stand here. And this is an arc which is equally distant from the target organ. So try to see that your ports fall on this arc, any number of ports. So that is the baseball diamond concept which you need to follow. And port placement cannulas, like your Hessen's cannula, there are port placement cannulas. Once these cannulas are in place, you can pass the instruments. And there are certain angles which you need to understand in this triangulation. Commonly, a neat examination and other things, they will be asking what is manipulation angle, elevation angle, what is azimuth angle, other things they will be asking. So the first one is the manipulation angle. That means the angle between the two working ports. So this is the central camera port. This is one working port. This is one working port. The angle between these two is called as a manipulation angle. See, for good ergonomic result, the manipulation angle should be 60 degree. As you have seen in this representation, the manipulation angle should be 60 degree. See, for example, I got two lap instruments are here. Suppose two lap instruments are there. 60 degree means something like this. Suppose if you put these ports too wide, you need to be operating like this. So this is 90 degree or 110 degree. Naturally, in this abnormal posture, so there will be spasm of your neck muscles, shoulder pain, joint pain. This is a very abnormal position which you should not use. So good one is 60 degree. Suppose you minimize this one, you make it some 30 or 40 degree, you will be operating again like this. See this abnormal posture. So again fatigue, joint pain, shoulder pain will be there. So good one is the surgeon should be relaxed. In a relaxed position, this is 60 degree. If you put too wide, you should do like this. This is not a ergonomically good position. Too close, you are doing like this. This is not a good position. See that surgeon is relaxed. This is 60 degree manipulation angle. And the other one is the azimuth angle. It should be 30 degree. So that means the angle between central optical axis, this is the camera, and the instrument. So some books will be wrongly saying that azimuth angle is nothing but it is half of manipulation angle. That is not right. Manipulation angle is between these two instruments, and this 60 degree should be equally distributed, 30 degree on one side, 30 degree on other side. Some what they do is they maintain this 60 degree, but between this central optical axis and working port it will be some 30 degree, here it will be 90 degree. So that should not be there. This 60 degree should be equally divided 30-30. You should not make it 15 or 45 or 10-50 or 25-35, that should not be there. So this azimuth angle means between the instrument and optical axis. In that you get a correct coaxial view. Suppose you have made them to one side, you are maintaining 60 degree, but it is well away from the optical axis. If it is away from the optical axis, instrument's hand is in relaxed position, but what happens to your head? You need to tilt your head. To see that your head also, the optical axis is good, this 60 degree should be equally divided between the optical axis and the instrument. Understood? So some people maintain this 60 degree, hands are relaxed, but this 60 degree, 45 on one side, 50 on one side. Azimuth angle is not equal, 45-15. In that case, surgeon has to turn his head and do the procedure. So neck pain will be there. So these two angles are very important. The other one is elevation angle. Elevation angle, again it should be 60 degree from the surface. So suppose if this horizontal plane is about the target organ, the instrument should be elevated about 60 degrees. Suppose if you observe from laterally, again for the surgeon to be relaxed, he should operate in 60 degree. Suppose surgeon is doing like this procedure, 80 to 90 degree, again it's not a ergonomically good procedure. So if you watch laterally also, from the horizontal plane and the instrument, it should be 60 degree. So these three angles are very important. See, manipulation, azimuth angle and elevation angle. So during triangulation, you should see that you take care of these three angles. So then only surgeon can do procedure without any ergonomically difficulty. And finally you have retraction. So R stands for retraction. So no procedure is possible without good retraction. So laparoscopy also, there are various types of retractors like fan retractor, you have different articulation retractors, S retractors, different types of retractors are there. Like in open surgery, laparoscopy also has got its own range of retractors which has to be properly used. Because whether in open surgery or laparoscopy, the dictum is you want to separate two planes. Both of them should be under traction. Once you put traction on two tissues, the areolar plane between them will open, like the honeycomb appearance. You can start dissecting in that planes. So you want to separate two structures, put them under traction. So good application of retractors is mandatory. And O stands for operation, the surgical operation. The laparoscopic procedure is very much similar to open procedure. So there is nothing new. Steps are same, but you are gaining access in a different way. So steps of procedure operation is same, only the thing is instrumentation difference. So you have all, whatever open instrument you have, a similar, its counterpart, you have a laparoscopic instrument. You have lap retractors, lap Babcocks, lap Alice is there, lap dissector, lap scissor, everything is there. And only the thing is instrument is long instrument which you need to accustom to. But steps of the procedure, operation is same. And of course, this is the laparoscopic view. You have got a good magnified view. Normally they say basic laparoscopic gives a 12 to 15 times magnification. So the advantage of magnification is you can preserve structures. The injury to the structures is very less because of good magnification. And I need not discuss more about magnification because you have a wonderful view of whatever. Suppose you are doing cholecystectomy in open surgery, we don't normally see the cystic artery, cystic lymph node of lung. If it is big enough, sometimes we'll be seeing. But in laparoscopy, you see nicely the cystic duct, cystic artery, any anomalous artery is there. Suppose you are dissecting the gallbladder from the liver blood. Once in a while, you get an anomalous artery. That also you can see in laparoscopy. Open surgery, we don't see all these things. So magnification, 12 to 15 times magnification. And finally, last S, I vitros. S stands for sealing or securing hemostasis. Securing hemostasis is very much needed in laparoscopy, like in open surgery. So whether it is open or laparoscopy, you need to secure the bleeding vessels. But in laparoscopy, not only you are trying to control a bleeding vessel, suppose there is a lot of bleed into the abdomen, your vision also will get impaired, because blood has got the capacity to absorb the light. So blood is there in the abdomen. One is you need to control blood loss. The other one is, if you immediately control the blood loss, you don't lose vision. So that is why, so suppose in open surgery, you are operating a big desmoid tumor is there in the rectus sheath, you are operating, suddenly there is bleeding on from one edge. There is no sputter, lot of blood is oozing out. Sometimes what we do, we put a mop, we ask one of the assistant to apply pressure, we dissect from the other side. But that cannot be done in laparoscopy, because if blood is there in the abdomen, you leave that one and you are operating on the other side, it will be keep on absorbing the light. The bandwidth will come down. So that is why good hemostasis, not only you are securing blood loss, you can actually preserve light by achieving good hemostasis. And like any open procedure, what are bleeding vessels are there, same vessels are likely to bleed in laparoscopy. But additionally, port side bleeding is one worrying thing in laparoscopy, port side bleeding. Because you are putting a port, the vessels underneath this rectus sheath, they might get injured, they will be bleeding. So suppose you notice a port side bleed. So normally what we do is, first instance we will just angulate the port. You have put a port, there is bleeding, simply angulate the port, apply pressure for some time. You can use the same port to apply pressure. The other one is, you can blindly put stitches like this, like hitches stitch. You can take a running stitch, you can simply, without noticing the blood vessel, on either side take some sutures and apply pressure. So if you apply pressure, most of the bleeding will stop. If still it is bleeding, use a bipolar and try to coagulate the bleeding site. So that is how securing hemostasis for not only the maintenance of hemodynamic circulation, to preserve light also. Methods like using port to apply pressure or blind stitches can be used for securing hemostasis. So that is about I vitros. So if we come back to the first slide, because this is given in Bailey, I need to speak about this I vitros. So I stands for insufflation, V mainly the visualization, the another I identification, newer landmarks, and T stands for triangulation, various angles you need to understand, R for retraction, and O operative procedure with different instruments, and finally S for securing hemostasis. So that is about the basic principles of laparoscopic surgery, and this is not complete without discussing about the advantages and disadvantages of laparoscopic surgery. So what are the advantages? The main one is small wound size. When wound size is small, all wound related complications like you have infection, bleeding from the wound, ports, the future dehiscence, hernias, all these things will come down. The wound is less complications, and you have all wound related complications, mainly the infection and bleeding, they will come down because of the small wound size, and less pain, because small wound you are cutting the tissues to the minimum, less pain will be there. Not only the cut of the tissue, retraction of the tissue also produces a lot of pain. In open surgery, you have opened the abdomen with a diverse retractor. One assistant will be continuously retracting the abdomen. Because of constant pull over the muscle, there will be trauma and pain. But in laparoscopy also there is retraction, but the advantage is you are retracting the abdomen by means of gas. So there will be uniform distension of the abdomen. All rectus muscles will be uniformly, the entire pressure will be uniformly distributed. So less traction, less pain. That is why, to see that this pain is less, proper port placement is enough. You are doing procedure through laparoscopy, but port placement is not as per the triangulation. In that case, what will happen? The assistant has to abnormally retract the port because the instrument is not reaching. He will be constantly pulling on the port. That way, again pain will increase. So the advantage of laparoscopy by uniform distension of the abdomen is gone if you put the port in a wrong way. So proper port placement will decrease the pain and early ambulation. So all complications with respect to prolonged bed rest, the lung atelectasis, pneumonia, lung infection, deep venous thrombosis, pressure ulcers, all these things can be prevented by means of early ambulation. And less heat loss. Open surgery, you are exposing the abdomen to the atmosphere. So lot of heat exchange. So hypothermia, again hypothermia induced cellular injury by means of acidosis. So open surgery, the viscera is exposed to the abdomen. Lot of heat loss is there. Lot of fluid also gets evaporated. So dehydration will be there. All these things will be prevented in laparoscopy. Less heat loss, less fluid evaporation, and improved visualization. So 12 to 15 times magnification. You can see all vital structures. You can see that they won't get injured. So these are all the advantages of laparoscopy. Because of early ambulation and early discharge, you are decreasing the cost. Though when compared to open surgery, laparoscopy procedure is costly, but if you calculate the quality working days, now here an employee can take only leave for 3 days. From 4th day after lap appendectomy, he can attend to his work. Whereas in open surgery, another 4 days bed rest. If you calculate this quality working hours, if you convert that into money, you are saving lot of money to the patient, to the hospital also. So price wise also, it's in fact very good procedure. But there are certain disadvantages with respect to laparoscopy, like remote vision. So you are not directly seeing the tissues. You are seeing the tissues from image captured onto a screen, and you are indirectly doing the procedure. The problem with remote vision is you don't have that direct feel of the tissue. So naturally, when you don't have this direct feel of the tissue, your hand-eye coordination will come down, and the surgery will be lot difficult for the surgeon, and lack of tactile feedback. So this is mainly useful in case of chronic inflammatory conditions and malignancies. See, suppose you are operating a case of there is a colonic malignancy. So there is a malignancy on the descending colon somewhere in the splenic flexure. You are doing open surgery. So in open surgery, you can nicely palpate the tissues. So you can see how much malignant induration is there. Suppose the tumor is, the diameter of the tumor is 6 centimeters. But if you palpate the colon, if there is tumor infiltration, the tissue texture will be gone. So just by palpating, you can say, okay, the tumor is 6 centimeters, but it seems to be spread till another 3 centimeters from the margin. So from there, you take a safe margin. Whereas in laparoscopy, what you see is what is the size of the tumor. So from the tumor edge, you will be preserving only 3 centimeters, but in fact, you are cutting through the tumor tissue. So that is mainly because you don't have a tactile feedback. That is lost in laparoscopy. Another one is, suppose you are doing, for example, cholecystectomy, you are operating. Sometimes there will be inflammatory induration. During open procedure, you can see how much induration is there, whether you are cutting through the indurated tissue. But laparoscopy, you can't feel that induration. You might be injuring bile duct and other things. So lack of tactile feedback is one major problem with laparoscopy. So that is why newer laparoscopy devices might come in future with haptic feedback. So where so there will be a sensor attached to your finger, and this sensor will give you the feel of the tissue, though what you call as an haptic feedback, but that is still under experimentation. So that is one big advantage. The other one is dependence on hand-eye coordination. See, normally in open procedure, what your eyes see, your hand will immediately go there, because from childhood you are accustomed. You want to pick a tumbler, you want to put your pen there, you want to grab something. What your eye sees, your hand will immediately go there. But in laparoscopy, because you are operating under remote vision, your instrument, it takes time for you to accommodate. Suppose there is a bleeding at one corner. In open surgery, if you notice the bleeding, your hand will immediately go there. But in laparoscopy, you need to take the instrument there, it takes some time for the surgeon to get accustomed to this one, to take the instrument where your eye want your instrument to go there. This you call it as a hand-eye coordination. It takes time, that by means of deliberate practice. So keep on practicing on laparoscopy trainer. If you keep on practicing on this trainer, you will develop this hand-eye coordination. Then you can do the procedure very easily. Otherwise, without good hand-eye coordination, you will be seeing surgeons struggling to catch the bleeding point. Sometimes the instrument will be going past that bleeding area, past pointing. They will be pre-pointing, because ultimately abdomen is a three-dimensional space, but surgeon is operating looking at a two-dimensional monitor. So he is operating in a three-dimensional space, but he is operating looking at a two-dimensional monitor. So that depth perception is not there. So that can be a bit prevented by using a 3D monitor. Suppose the monitor is 3D, abdomen is a 3D space. By using a 3D monitor, you can you can grab hand-eye coordination quickly. But again, 3D monitors, they are very costly. So like in our hospital, we have a 2D monitor. So operating in a three-dimensional space, looking at a 2D monitor, this depth perception is very difficult to acquire. So lot of times you will be seeing, suppose a needle is there in the abdomen. To pick that needle, surgeon will be struggling. Pre-pointing will be there, past pointing will be there. All these things will improve the operative time. More operative time, more carbon dioxide, more hypercarbia. And in that past pointing, you might be injuring a vessel also. So that is why, to develop good hand-eye coordination, practice, repeated practice on lap trainers. That is depending on hand-eye coordination. And a difficulty with hemostasis. So the problem is, like whenever there is blood in the abdomen, light will be absorbed, light will be diminished, and sometimes the blood will spill onto the camera also. In that case, the assistant has to bring out the camera, he has to clean that one. By the time he reinsert the camera, the entire field will be with pool of blood. So when compared to open surgery, controlling hemostasis is a bit difficult in laparoscopy. That is why the best one is prevention of undue hemostasis. So operate step by step, carefully, see that there won't be any accidental bleed. And learning curve. So laparoscopy takes time to learn. So that is why those who are accustomed with open procedure, take some time. Keep some possible target. Like, so for example, you have finished your MS, you are well versed in open procedures. You want to start doing laparoscopy. Keep a reasonable time of some 6 months to 1 year. Practice on endo trainer, assist some procedures, then gradually build up. So impossible targets, like you want to do lap appendicectomy from the next day itself, or you want to do lap cholecystectomy in 1 month. All these impossible targets cannot be achieved. It takes at the cost, if you do those procedures at the cost of injuring some vital structure. So it takes a bit of time, learning curve is there. So respect that curve. And finally, how to extract large specimen. This is another big problem with laparoscopy. Unless you need to cut the tissue into pieces, in that process you will be seedling the tumor deposits. And there are things like morcellators or liquefier, some devices. If you put a morcellator, that will just scoop out whatever. Suppose you have done laparoscopic splenectomy, you need to remove the spleen. But spleen cannot come out through this port. You need to give a big incision. Then that is as good as open procedure. For that, some people use morcellators. Morcellator, it's a high power suction where you put that into the spleen, it will scoop out. But where is the specimen for histopathology? By scooping out, you don't have any good specimen for histopathology. So that is why another problem with laparoscopy is how to extract large specimen. For that, you need to increase the size of the port, or you need to do a mini laparotomy. So these are some disadvantages with laparoscopy. But another important one in disadvantage in laparoscopy, the paradoxical movements. See, for example, we are doing open surgery, we are doing a procedure. For example, I am doing cholecystectomy. So I am trying to cut the Calote's triangle. So I have cut the Calote's triangle. Open procedure, assume that I am doing an open procedure. I have cut the Calote's triangle. The vessel got retracted some 1 or 2 centimeters laterally, it is bleeding from there. What I will do immediately, I will move my hand towards the bleeding vessel and try to hold that one. So this is the normal movement. But what happens in laparoscopy? Laparoscopy, suppose the same procedure, assume this is the port. I am doing the procedure through the port. Same, I have cut the vessel. the vessel has retracted for 2 centimeters. Can I move the instrument like this? No. I need to move the instrument in opposite direction to see that I go towards the right. To go toward the bleeding point, open surgery, I move my entire hand towards the bleeding area. But in laparoscopy, port is limiting that one. So you need to move in a counter direction. Then only your instrument go there. So this is the paradoxical movement. This you get by the surgeon immediately. Once you see that one, this paradoxical movement, this comes only by practice. So this this paradoxical movement is another limitation by laparoscopy. That is why this learning curve, all these past pointing, pre-pointing, hand-eye coordination, paradoxical movements, you need takes some time to understand. That is one disadvantage. The another one is in the learning curve, fulcrum effect. So there is a thing called as fulcrum effect. Again, suppose if this is the port, you have put the instrument like this. During surgery, you see that half of the instrument is in the abdomen, half of the instrument is outside the abdomen. Then suppose I move my device by 1 centimeter. The whatever is in the abdomen, it also moves by 1 centimeter. So this equal should be there. Suppose this is the port. I have introduced instrument too far. The inside 3/4 of the instrument is inside the abdomen, only 1/4 is outside. Now see, if I move it by 1 centimeter, this inside one will move by 2 to 3 centimeters. So naturally you will be injuring tissues. Again at the same time, more length of the instrument is outside the abdomen. If I move 5 centimeters also, it will be moving 1 centimeter. So this is called as fulcrum effect. So for that, surgeon has to see that exactly half of instrument is inside the abdomen, half is outside the abdomen. In that case, the 1:1 movement will be there. So all these things, you get acquainted to all these things only when you do practice, you assist procedures and do them. So these are some disadvantages of laparoscopy and future of laparoscopy. Like you have the all the sills, nodes, poem, robotic surgery, sills port. Instead of putting 3 ports, one port will be put. The same port will be having 3 small openings. Through that, the camera instrument will be introduced. In that case, the instrument should be slender and the instrument should bend like the spider claw. Then only sills port you can do procedures. That is one thing. You can avoid multiple ports. And notes, these things need a separate class to discuss. So through the natural orifice also, like you can see here, they have put a small rent in the esophagus. The instrument is brought into the abdomen. They are trying to do laparoscopectomy. And one instrument is coming through the rectum. So natural orifice, transluminal endoscopic surgery, this is one modification. Finally, where you don't see any external port. And you have poem, the peroral endoscopic mucosal resection and other things for achalasia cardia and all these things, that they need a separate class to discuss. The other finally robotic surgery, where instruments with versatile flexibility and improved magnification and improved energy devices, you can do procedures. So these are the futures of laparoscopic surgery. And what I am saying, future of laparoscopy, already it is present day. So now the sills they are doing, nodes they are doing, poem they are doing, and robotic surgery they are doing. So laparoscopy is progressing at a brisk pace. So to the surgeon, as tomorrow's surgeon, you need to chase that one. You need to fall in that pace. For that you need intense training and practice. So that is about laparoscopy, advantage, disadvantage and other things. So eye vitros, remember that one. You can write the principles of laparoscopic surgery. Right, thank you.